we're going to be talking about microinvasive rapid recovery surgery for nerve and tendon entrapments. So if you're thinking about having surgery and don't have a lot of downtime, this is something you're really going to want to listen to. So welcome back to the show, Dr. Markison. So nice to see you.
Nice to see you. Thank you.
So we were just talking a little bit about this new approach that you have, microinvasive surgery. Can you tell us what it is and when it's called for?
Yeah, a little background. In 1987, I first published ultrasound guided hand surgery for the drainage of deep space infections, mostly in the hands of homeless people in San Francisco. And then fast forward to the current time where you've got very portable, high resolution ultrasound technology where you can diagnose things and guide instruments in the operating room using ultrasonography. And so I published some on that, techniques, articles, and so on. Used an initial device for carpal tunnel release called the Manos, M-A-N-O-S device. And that kind of gave way to the Mayo Clinic's development of the Sonex microknife that is ultrasound guided. And you can do a very minimal approach for carpal tunnel, and I'm using it for other things as well. But as people are working remotely, they're often in odd positions and their tunnels are tightening, whether it's tendon tunnels, de Quervains, tendon tunnels, trigger digits, carpal tunnel, cubital tunnel, and sometimes other tunnels, with or without coincident and contributory neck level problems. And so people can spare minimal downtime, if any. And those doing physical work with social distancing out in the real world also can't spare much time. So microinvasive is kind of the theme, and beyond that, it's wide awake, local anesthesia without need for a tourniquet. And I have some people in high risk groups, whether they're on blood thinners, diabetes, thyroid disease, comorbid factors that weigh against even a big anesthetic. And they're trying to sustain themselves and live and work independently into their 70s and 80s and some in their 90s. I have a broad patient demographic, age 10 to probably age 96 currently. So with that, I can give you an idea of a microinvasive Sonex technique, S-O-N-E-X technique. I have no financial interest in any of the instrumentation I use.
The advantage would be that it's less, it sounds like you can go in, you don't need major anesthesia. Did I hear you correctly?
It's just pure local anesthesia. Patients wide awake, conversational. I'll ask them to move their thumb and fingers, make sure they're comfortable, absolutely confirming normal or varied anatomy in real time with high resolution ultrasonography, and guiding a little probe initially through the carpal tunnel, removing that, putting in the twice tested little Sonex device with a little microknife that stays in its little home. And then you deploy it, watching ultrasonographically, cross-sectionally and longitudinally as you completely divide the roof of the carpal tunnel without disturbance of the overlying muscle and fiber tissue and crisscrossing nerves. And then you deflate the balloons astride the device, undeploy the blade out where it started, and then withdraw the device. There's no bleeding at all. You're in through 3 or 4 millimeter incision at the wrist. And a single suture or no suture comes out at 5 days. Get it moving and the patients are happy. And I guess in the ultrasound world, having done more than 280, probably close to 300 of these, using initially Manos technique, currently Sonex technique, they've done very, very well. We're talking about symphony, opera, ballet, orchestra players and a worldwide menagerie of hand-intensive people, but of course the workaday hands that are doing intensive, now remote work at high velocity. So that's just one point, a simple, minimal downtime, microinvasive ultrasound-guided carpal tunnel release with release of any tightness on the near side proximal to the inlet to the carpal tunnel. If it's a carpal tunnel release that needs opening for one reason or another, anatomical variation, early crossover of a vessel and so on, all of which is detected in the office preoperatively, fine, we open and we do a minimal incision open technique release, still gets us out here, gets us here. And if somebody's had a carpal tunnel release inadequately performed previously or possibly recurrent, then I'll go ahead and open it. But 95% of the time, patients are very happy and anatomically suitable for the microinvasive technique.
So you'd need a doctor who was skilled and knowledgeable about the timing of when to use this microinvasive technique as opposed to something more traditional.
Well, it's absolutely right. 25% of American hand surgeons, with a growing fraction, are ultrasound literate sufficiently to diagnose in the office, a slightly smaller fraction capable of ultrasound guidance, of microinstrumentation to do things. So it's just worth asking the doctor, are you comfortable, at least on the diagnostic end, doing ultrasonography to detect the problem, its nature, severity, and possible anatomical variations. It doesn't mean you cut the doctor out of the herd immediately if they don't know how to do that, but you'd like regionally to have access to somebody who does. And then when it gets to surgery for that kind of thing, you'd probably like to have a board certified hand surgeon, someone who carries a continuous certification, certificate of added qualification in surgery of the hand. Not absolutely essential, but I think helpful, because there may be coincident problems, perhaps something like a thumb joint replacement needs a little more anesthetic, coincident release of trigger digits, of de Quervains, other nerve entrapments. So it'd be nice to have somebody who's dedicated life to limb.
Do you think that this, can you use this sonography in the other kinds of surgery as well? Because it sounds like it would be very precise to be guided by the sonography.
Yeah, I'll give you another example. As you may know, trigger digit is where you've got a tight tunnel on the near side of a set of graduated rings that hold tendons against skeleton. The first annular pulley, annulus Latin for ring. We wear rings on the inside, and so this one gets tight, and so that sticking of a finger where they in the morning have to mechanically straighten it, called trigger digit. Well, it is possible, and initially with this Mayo Clinic device, the Sonix device, maybe about 14 surgeons nationwide started doing it. We had to have a track record. They knew my record of ultrasound guided surgery and diagnosis and treatment and office follow-up and so on. So I was blessed to be in the initial cohort of surgeons, but that fraction is growing. And so again, not everybody's a perfect candidate for it, but once you get nimble with the guidance of instruments using ultrasonography, avoiding critical structures, very, very minimally invasive. You have patients who are delighted. They don't have any anesthesia beyond local. And I call every patient as a matter of, I guess, moral fiber sentiment and checking up on them every time I do surgery. I call them the next day. They're pain-free, raring to go and happy. They might rarely take a Tylenol, but that's rare. They don't have any tenderness because we've been on the inside. And they get their feeling back quickly, depending upon the nature and severity and duration of the carpal tunnel. But they're happy. And so we haven't done a big physiologic disturbance to them. Now, sometimes we also have to release another tight tendon tunnel called de Quervains, which is the thumb is abducted and extended by tendons that go through the first of 6 extensor tunnels. And so people feverishly doing this, working on the keyboard and so on, space barring, may get tightness there. So that's called de Quervain stenosing tenosynovitis.
Long, very medicated trip to
rehabs are very minimal. Another common entrapment is cubital and tunnel syndrome, where the ulnar nerve that gives you feeling in the ring and little fingers is pinched behind the funny bone. And that can be weakness of any of the 15 of 20 small muscles wired up by the ulnar nerve, and more often presents with numbness in the little finger and half of the ring, as opposed to carpal tunnel, thumb, index, middle, and the other half of the ring. So I'll give you an example of one of those. Let's see if we can get that up here. Nothing but great. In fact, he had a combination here and here. So cubital tunnel, carpal tunnel, simultaneously addressed in a microinvasive fashion. So let's see back to the whole thing. And he also plays piano. And so, the combination of having to do computer use and then having a separate world of increased scope of limb use, you want to you want to get people well quickly, and you want to get them back to all their activities, whether it's work or play. And so these are very happy people undergoing microinvasive work with rapid return to work.
I know one of the things that I always tell people is that you can't use your other hands to play the piano. You only have one pair of hands, so you have to take care of them under all circumstances.
Absolutely. So, I mean, thematically here in this little video, it's about plenty of hope for those who worked remote, in or out of home, and they get little tight nerve tunnels, tendon tunnels. You just get it taken care of by someone who knows what he or she is doing, and they're going to do fine. No fear, no dread.
Good. Well, thank you for sharing all of this with us. Thanks everybody for watching, and we're going to have Dr. Markison back on the show really soon, so stay tuned.